Alright, so here we are now, basically moving on to movement disorders. We wrapped up dementia last time. The movement disorders are just two things, really. There's Huntington and Parkinson, and there's a little topic about restless leg syndrome, which by definition is a movement disorder, but not really. So for Huntington, a rare hyperkinetic autosomal dominant disease involving the CAG triplet repeat sequence in the HD gene on chromosome 4. So HD gene is just a Huntington disease gene. The number of repeats typically expands in subsequent generations, leading to earlier expression and more severe disease, which is the concept of anticipation from first aid step 1 genetics. Life expectancy is 20 years from the time of diagnosis. Now, I'm not sure why they worded this way, because remember from back in step 1 there was this concept of not really looking at things based off of when the diagnosis occurred, right? Because you don't really want to fall into that kind of a bias. Rather than looking at when the diagnosis occurred, you're really supposed to be looking at from when the first few symptoms occurred. So that's something to keep in mind. I'm not sure if they really meant to word it this way. I'm pretty sure they meant life expectancy is 20 years from the time of initial symptom onset, with tremors and everything. Presents at 30 to 50 years of age with gradual onset of chorea, which is purposeless, involuntary, dance-like movements, altered behavior, and dementia, which begins as irritability, clumsiness, fidgetiness, moodiness, and even antisocial behavior. Weight loss and depression may also be seen. Clinical diagnosis is confirmed by genetic testing, right? You would look for the CAG repeats. CT or MRI shows cerebral atrophy, especially of the caudate and putamen. Treatment: there is no cure, and disease progression cannot be halted. Just treat symptomatically and keep them alive for as long as possible, right? So what you're looking at here, they're showing you the CTs. Non-contrast CT in a 54-year-old patient with Huntington disease shows atrophy of the caudate nuclei, right, where your caudate would be, and diffuse cerebral atrophy with dilation of the lateral ventricles. So a normal 54-year-old subject is being shown in B, and you can see the key differences. Right, so the lateral ventricle is really big and wide here because the caudate that was supposed to be sitting in there is now gone. So your caudate nucleus would be like something like that on both sides. It's kind of been atrophied, right? So it's no longer there. So this is a nice little side-by-side comparison of what you'd be looking for. Again, like questions, as you could tell right here, there's not much being explained to what you would know or what you would look for in a Huntington disease patient. A lot of it is because they don't really like to repeat things they already talked about in step 1, so we'll go back and look at first aid step 1. But generally speaking, a lot of things here will mimic other things. Now, one thing I like to revise is this concept of chorea. So of course, with most grown-up patients, 30 or above, when you see them with chorea, you do consider Huntington disease. There's another case scenario we can get chorea, and it's not Huntington disease. And that, let me see if I can find it. So that should be somewhere in microbiology. Let me see. No. It was one of these guys. I can't remember exactly which one. I'm pretty sure. Let me zoom in. Pretty sure it was this guy. Where you would see chorea in a younger individual. And then when you do see that chorea in a younger individual, it's because of things being deposited in a certain part of the brain that is causing that symptom, and it's not Huntington. So basically, you should keep in mind infectious causes where things can be deposited, causing chorea, and it's not exactly due to Huntington. So this is just bringing us back to Huntington. So if I find it later on, I'll remind you guys. But let's actually look at Huntington here now. in the step 1 neuro section. So there's a couple of things to keep in mind for Huntington, right? So first of all, they did a good job in that other place showing you the loss of this, right? So I put this picture here to show the same thing. This one is a little bit of a higher CT scan, showing you the same thing, that this section is gone, right? The caudate nucleus has atrophied. If you go a little lower than what level this is at, then you would see that the lateral ventricle has expanded because the caudate is gone, and that's why you would have low acetylcholine, right? So in Huntington disease, you have low acetylcholine and low GABA, and you have high dopamine. Right, so acetylcholine is a parasympathetic for rest and digest, so you remember that they don't really rest much. When you don't rest much, you can't really have good memory either. You need to sleep to get good to have good memory and stuff. So they have a lack of parasympathetic resting activity as well as memory. And without GABA, you can't stop. GABA is inhibitory, can't stop moving, so they end up having excess motion, which equates to the activity of dopamine. Right? Remember, dopamine was in the basal ganglia responsible for turning on motion through the direct pathway or through inhibition of the indirect pathway. Right? Chorea is involuntary irregular fidgety movements, and atetosis is a slow convoluted writhing movement, all of which are things that can be described in questions with a lot of words like this, and then you would have to figure out that the question is really trying to push you into thinking Huntington disease. And then the expansion of the lateral ventricles here is not exactly a hydrocephalus. It's more so called ex vacuo. It's a different type of hydrocephalus. Hydrocephalus ex vacuo. When you see that, that's when you know that it's not that you really have hydrocephalus, but more so that you lost some of your brain. Right? That the brain has disappeared, causing it to look like hydrocephalus, but it's not really hydrocephalus. So the CAG, right, you can remember cage for hunting by thinking of cage for hunting will remind you of the CAG and chromosome 4 for Huntington. Also, the CAG should remind you of caudate loses acetylcholine and GABA, because you will need to remember these hormone changes, right? Now, the Huntington gene, so there's this picture, right? Transcriptional repression in Huntington disease. So the Huntington gene makes this mutant Huntington, as you can look at right here. The mutant Huntington has a very specific pathophysiology that is now becoming more and more prominent in questions. It actually stops histone acetyltransferase. So remember, acetylation of histone causes histone to open up, right? So if you don't do that, then you can't open it up. You don't have relaxed chromatin. So the histone acetyltransferase is not going to work. Histone deacetylase will work, which is essentially similar to activity like histone methylation. So it takes the relaxed histones and coils them all up tightly. Now you're going to have decreased transcription of neurotrophic factors, things that are good for brain, right? Good for your neurons. Without those neurotrophic factors, you get impaired neuronal survival, which then leads to Huntington. Right? So the key pathophysiology of why brain dysfunction occurs in Huntington disease is histone deacetylation. Too much histone deacetylation. You stopped histone acetyltransferase. That's the direct mechanism. The mutant protein that you make because of this repeat, the CAG repeat, is going to cause you to stop histone acetyltransferase. So you have too much deacetylation, and you get your tightened up chromatin, which is really not going to get transcribed at all. Right? So this is the general key thing to keep in mind for how you have pathophysiology in Huntington disease. Over here, if a 43-year-old man presents with gradual onset of chorea, irritability, and behavioral disturbances, and his father also experienced these symptoms at a slightly older age, you immediately think Huntington disease, because remember the autosomal dominant aspect, right? So it is going to have family history. They go on to say, under treatment, they go on to say reserpine or tetrabenazine can be given to minimize unwanted movements, but again, those are just strictly symptomatic things that you're trying to maybe make quality of life a little better. Psychosis should preferably be treated with atypical antipsychotics to decrease the risk of extrapyramidal symptoms, extrapyramidal side effects, or tardive dyskinesia. SSRIs are a first-line therapy for depression. So for these people, when their depression starts getting out of hand, maybe they're not sleeping at all, or maybe they're always crying or something, then once again, to make quality of life better, just prescribe SSRIs, right? Don't give them any really bad psychotic medications and antipsychotic medications, because what happens there, as we've seen, is the presence of really bad Parkinsonian side effects, right? So it would be really unfortunate to cause a Parkinson patient to end up having Parkinsonian side effects. So if we look at antipsychotics, right, we have a bunch of them, and they all have so many side effects. All your typical first-gen and atypical antipsychotics, right, they share in these side effects. So this is the first day 2021 breakdown, where they've kind of restructured it all in a different order. But generally speaking, you know that the typical antipsychotics are more likely to have extrapyramidal symptoms, right? That's why here they tell you that preferably should be treated with atypical antipsychotics, but not the typical ones, because typical antipsychotics are more likely to cause extrapyramidal symptoms, such as acute dystonia, and then akathisia, Parkinsonism, right, and tardive dyskinesia, all of which can be treated with benzodiazepines or benztropine here for the Parkinsonism, right? So benztropine, right, benztropine, and then benzodiazepines here. So you have to remember these medications, because the questions you get on Parkinson disease are no longer ever going to be like, oh, what disease does the person have, and you just pick Parkinson and you're done. No, it's going to be a lot harder than that. So now they're going to start combining psych with Huntington. That's the most common type of question you'll really ever see on Huntington, where you get a patient with Huntington disease, they start talking about the depression the person is having, and then they'll be like, what medication should you give? And they'll put a bunch of medications. But if they have an SSRI listed, fluoxetine, sertraline, any of those, you pick that. That's the first line therapy for depression in Huntington disease. Not in everyone, but in Huntington disease patients. Don't really want to pick typical or atypical antipsychotics, but if they don't have any SSRIs listed, then they might have listed a bunch of random things like tricyclic antidepressants, and then all the typical ones, and maybe one atypical, like quetiapine. So you pick quetiapine. You want to give the atypical antipsychotic, not the typical one. The typical antipsychotics are almost definitely going to cause extrapyramidal symptoms, right? So that's something you want to avoid. You don't want to worsen the Parkinson side effects. New gene therapy trials to reduce or eliminate triple repeats are underway, and genetic counseling should be offered to offspring, right? So very important to make sure you check for genetic counseling, because if you know that a certain family, let's say that you're dating someone and someone in their family has Parkinson's, then you don't really want to marry this person now. And you want to make sure that the triple repeats in them haven't really occurred at all, or are as minimal as possible, because unfortunately this is something that gets passed on. And it would be very selfish to give birth to a new child who's also going to carry on more Parkinsonian side effects. It's just not worth it. You don't want to give birth to Parkinson's, right? So, it's like a very big ethical topic, but generally speaking, the fact there remains that if you have Parkinson's, it's probably best to not reproduce, because you're going to just give birth to more Parkinson's. And nobody wants to live with Parkinson's, right? So it's like a death sentence. You're giving birth to a death sentence. And it's a problematic thing. So genetic counseling, the reason they even mentioned this here is because as physicians, especially on step 2 now, a lot of the questions are going to be based on, besides the psych combination, a lot of questions are going to be based on the ethical concept of conversation, because CS is gone now. So they're going to ask you, like, what would be the best response to give to this patient? And you should just say, do genetic counseling to check for how many triple repeats there are. Because if there's a lot of triple repeats, then remember, the more triple repeats there are, the worse the anticipation. The earlier the disease onset is going to be, the more severe the disease onset is going to be. You don't want to do that. You don't want to fall for that. The gene therapy trials that are happening are still too new to really be put into effect. Plus, it takes time to even get results, because it's not like this is a disease you're preventing, like taking the COVID vaccine or something. but more so therapeutically, you're trying to get rid of triple repeats, and then you wait for this person to now have a child, and then in that child, you're going to check for how many triple repeats they have, and you're going to wait for that child to grow up to see if that child gets Parkinsonian symptoms. So this is like a multi-generational therapy. So it's going to take more than just one scientist and one physician working on it. So with Huntington, you want to be very careful. Now, another thing that people confuse is the confusion between Huntington and Parkinson's, right? So of course, the symptoms that occur in Huntington disease, a lot of them mimic what occurs in Parkinson's disease. So you don't really want to give a Huntington patient for their medications anything that would cause Parkinsonian side effects. The symptoms that the two things have are very similar. Another thing that's critical is understanding and remembering that there's excess dopamine here, right? There's a lot of dopamine here. Remember that the only other place you had high dopamine was schizophrenia. And schizophrenia was the one with the really high dopamine levels, and that was pretty much the only key thing there. Right? Schizophrenia, really high dopamine. That's it. Nothing else happened in schizophrenia. So if you look across the table, where else do you see high dopamine? Huntington, which causes excess motion, right? Too much motion. So that's pretty significant, because now you can imagine that it might be possible for Huntington patients to have very psychotic symptoms, which is exactly what schizophrenia is, right? This is why the two things get tested very closely. Let's go back to, and then now we're going to be looking at Parkinson's. So since we're on this page, in Parkinson, the arrows are exactly the opposite. So in Parkinson's, you actually have low dopamine. That is what Parkinson is by definition. You lost your substantia nigra, pars compacta, right? You lost your SNC. So since they don't have their substantia nigra, they don't have dopamine. Now remember, without the dopamine, no activity would occur in the basal ganglia, so there would be no motion. Right? So Parkinson patients are not going to have much motion at all. And since there's always a balance between acetylcholine and Parkinson, if your acetylcholine and dopamine, if your dopamine is low, acetylcholine will become very high. The two guys are balanced. This balance between the two hormones isn't really discussed much anywhere, but you should keep in mind that it is a fact that the two are balanced with each other. Right? So you would never have a person with high acetylcholine and high dopamine. It doesn't really work that way. So in these people, the key issue, loss of dopaminergic neurons. Right? You don't have the substantia nigra pars compacta. It's going to be depigmented, and they're just not going to make any dopamine. They also get Lewy bodies, which are alpha-synuclein eosinophilic inclusions, as we can see right here. Right, tiny pink inclusions inside the various cells in the brain. Parkinson traps your body because you can't move. So you get tremors, rigidity, which is going to be the cogwheel rigidity, the most important thing, in my opinion, for you to figure out that it's not Huntington, because you don't get rigidity in these people. Right? You get chorea. They're like dancing. They can't stop moving. Right? Athetosis, which is also moving, right? Breathing movements. But here you get rigidity. You get akinesia or bradykinesia, postural instability, and a shuffling gait where they can't really walk correctly because, once again, you can't move, right? There's no motion. MPTP is a type of a thing you find in drugs. It's a contaminant in illegal drugs, metabolized to MPP+, which is toxic to the substantia nigra. And once you get rid of your substantia nigra, you basically mimic Parkinson's disease, right? So coming back to CK, if we move over to Parkinson's, you get a primarily motor disorder that usually begins after 50 years of age and is caused by loss of dopaminergic cells, initially in the substantia nigra. Parkinsonism has symptoms similar to Parkinson's disease and can be caused by antipsychotic use, multiple subcortical infarcts, toxin ingestion, and trauma. And you get all of these in questions. So Parkinson has its own little set of things that make questions very difficult. You'll get a patient that really looks like they have Parkinson's disease. But then it wasn't just Parkinson's disease. It turns out that because they've had so many subcortical infarcts in the brain, that now they have vascular Parkinsonism. You can have Parkinsonism because of the various antipsychotics the person might be on. So Parkinsonism can occur secondary to other things, and that's not true Parkinson's disease. That's just Parkinsonism. That's just symptomatic Parkinson's, where you look like you have Parkinson's, but you don't really have Parkinson's disease. They go on to say that there's a history of Parkinson tetrad, 4 things: resting tremor, rigidity, akinesia, and postural instability, just like we saw in the other book, with the trap mnemonic. So they put that here too. Other manifestations are going to be masked faces, memory loss, and micrographia. There's always a bunch of other things you're going to see as well, but nothing is really specific and a giveaway for Parkinson's disease. Now, unlike Huntington, you can actually try treating this a little bit, because here the only issue is you don't make dopamine, so what can you do? You give dopamine, right? So that's a treatment you can actually use here. With Huntington, remember the problem was that you had that Huntington mutant protein that was causing too much acetylation to win, so you couldn't do transcription anymore. There's nothing you can do about that part. So here we see levodopa-carbidopa combination, mainstay of treatment. Levodopa is a dopamine precursor that can cross the blood-brain barrier. Carbidopa blocks the peripheral conversion of levodopa to prevent the side effects of levodopa, which include nausea and vomiting. Early side effects are hallucinations, dizziness, headache, and agitation, but late side effects are involuntary movements, which are going to start causing a Parkinson patient to start looking like a Huntington patient. Dopamine agonists like ropinirole, pramipexole, bromocriptine can be used for treatment in early disease. Side effects of those dopamine agonists are hypotension, somnolence, confusion, compulsive gambling, a big one. Next best treatment is selegiline, a MAO-B inhibitor, which you have to be careful with, because if they take anything that requires MAO-B, you're going to have an overdose. Maybe neuroprotective and may decrease the need for levodopa. But side effects, again, just confusion and insomnia. They don't really break down the form too much here, so we'll go back and look at it in step 1. You have COMT inhibitors like entacapone and tolcapone, and anticholinergics. This is most commonly in acid choice. Just like that, not even one of these as an acid choice, but directly anticholinergics. Generally used in younger patients whose primary symptom is just tremor. Right? So if you have a younger patient, maybe someone who's actually new to just now being diagnosed and just now starting getting symptoms of Parkinson, and maybe they have only one symptom, which is a little bit of tremor, all you need to do is give them anticholinergics. Because remember, in Parkinson, you have high acetylcholine. So the high acetylcholine is causing all this acetylcholine-related stuff, so you just give them anti-acetylcholine, right? But, of course, if you get rid of all the acetylcholine, if you overdose or the anticholinergics are just having a very strong effect, you're going to lose the parasympathetic things that you would do. And one of the key things that gets tested with anticholinergic use is the levator reticularis. The other things are very obvious: urinary retention, constipation, dry mouth. Those are all the most common and the most obvious anticholinergic symptoms. You can't eat or sleep or pee, right? You can't do the rest and digest. But levator reticularis is a very weird side effect that takes place in anticholinergic use, and you have to catch that. You have to know that when they show up with levator reticularis as a patient of Parkinson, then it must be because they were taking anticholinergics, right? That's kind of what they're going to ask you about. This thing we saw a question on, the surgical pallidotomy and deep brain stimulation. So if medical therapy is insufficient, then you pick this. So first of all, don't even think of the pallidotomy or the deep brain stimulation as an acid choice you should pick if you haven't yet done medical therapy. Right? You need to do the medical therapy first. And then if medical therapy really isn't helping at all, you could do deep brain stimulation, where you would most likely stimulate the subthalamic nucleus. That was what we saw in one of the questions. By stimulating the subthalamic nucleus, you would make it look like dopamine did its thing, and then you would get motion. You would successfully form motion. Here they had a question in the book itself. This one said, a 65-year-old man presents to his internist with 10 years of bilateral hand tremors. His mom and older brother have similar tremors. He denies difficulty concentrating, trouble with rising from a seated position, or even recent falls. What is the most likely diagnosis? Well, he's got family history of the same tremors, and all he really has is tremors. So what do you pick as a diagnosis? Well, essential tremor is the most likely diagnosis. That's it. Not anything else, because they did a good job canceling out other things. He doesn't have difficulty concentrating. He doesn't have any difficulty standing up. He hasn't had any falls. He doesn't have ataxia. So it's not going to be one of the other things you might be quick to pick. It was just essential tremor. Unlike the resting tremor in Parkinson's disease, essential tremors are suppressed at rest and exacerbated with movements. Remember that bilateral tremors are less common in early Parkinson's disease, and patients with Parkinson's disease are more likely to present with multiple symptoms, which the guy didn't have. He only had tremors. Treat essential tremors with beta blockers, primidone, and topiramate. Mainly, the question is just give a beta blocker, like propranolol. Right, so that's your essential tremor. Nice little differential to keep here. This is another key fact thing that's actually pretty nice. Location of cell death determines the phenotype of disease. For example, in Parkinson's disease, you have cell loss in your substantia nigra, so you lost dopamine. So that's definitely Parkinson's disease. In Alzheimer's disease, there's a temporal lobe cell loss, so acetylcholine and norepinephrine both end up being low. In ALS, we saw earlier that that's a spinal cord cell loss, and myasthenia gravis, you actually block acetylcholine activity. This is very grave, because you don't even have the receptors for acetylcholine. Right? So that's the issue in myasthenia gravis, and so on and so on. This list can be even longer. There's all kinds of things. Basically, they're talking about what are the things that define a disease, right? Anatomically speaking. Over here, they talk about a significant difference between the gait abnormalities of Parkinson's disease and that of normal pressure hydrocephalus is preservation of arm swing in normal pressure hydrocephalus. Right? Normal pressure hydrocephalus doesn't have swinging of the arm, but Parkinson will. Parkinson is going to have that weird entire postural instability. Right? So everything is messed up. Arms, legs, and all of that. Normal pressure hydrocephalus is just the wet, wobbly, wacky. Right? So that was the mnemonic for that stuff. Watch for Parkinson plus syndromes. Right? So multisystem atrophy is Parkinson plus autonomic dysfunction. Or Lewy body dementia is Parkinson plus visual hallucinations. Right? Where it's not just Parkinson. So Parkinson is going to have a lot of differentials, and it's going to be very difficult to figure out what exactly is the person presenting with. Is it actual Parkinson's disease, or is it something that's causing Parkinsonism, and it looks a lot like Parkinson, but it's not just Parkinson's disease. So you're going to have to use your best understanding of all the collective symptoms the patient is presenting with to figure out whether or not it is Parkinson's disease. But generally speaking, treatment usually is the same stuff, so at least that aspect is nice. But if the question is asking you to figure out exactly what the problem is, then it gets a little difficult, right? So before we go into the questions, let's actually go back and revisit some of the form for Parkinson. Neurology. So there's an entire page for Parkinson's disease drugs, right? And remember I mentioned that the livedo reticularis is a key thing, so this is what that looks like, right? This is going to be seen with your the anticholinergic treatments. You can also see it here. So let me see what they said here actually. Livedo reticularis with the anticholinergics, right? And did they put livedo reticularis for the earlier stuff too? They didn't put it for anything else here, only for anticholinergic. But here they tell you, right, that dopamine agonists, medications like amantadine, which increase dopamine availability, can also cause livedo reticularis. So there's multiple medications that can cause this to occur in these patients. Right? You don't want to think it's some kind of vascular disorder, and don't let this trick you into thinking maybe it's some kind of cancer or something. No, it's just a side effect of the medication they're taking, either the amantadine or some anticholinergic. All right. So first things here, dopamine agonists like the ergos, bromocriptine, or the non-ergos like pramipexole, ropinirole. Right. The non-ergo dopamine agonists are preferred. The only issue is that they can cause impulse control disorder, like impulsive gambling. They can also cause hallucinations and confusion, which again is always problematic. But it's very hard to treat Parkinson as it is. So you use what you have, right? L-DOPA availability increase are agents that actually allow you to have more dopamine. So there's levodopa and entacapone. Now here they do a good job showing you where all of these guys work, right? So carbidopa is a dopa decarboxylase inhibitor, right? It stops this so that L-DOPA can stay L-DOPA, and now get converted to dopamine in the peripheral area. So now the L-dopa is able to make it into the brain, where you have your own dopa decarboxylase in the brain as well, making it into active dopamine. Right? The other enzyme that converts L-dopa peripherally is COMT. So you take COMT inhibitors like entacapone and tolcapone. Tolcapone, I always think of it as a toll, because this gets tested in very weird questions. I think it was more common in step 1, hopefully not going to be that common in CK. But you think of it as a toll, like the toll of a bridge, where you have to pay a toll no matter which way you come from, right? So when you get onto the bridge, no matter where you got onto it, there's a toll on both sides. So tolcapone works on both sides. It works in the peripheral area as well as the central inside the brain, past the blood-brain barrier, right? And its job is to stop COMT from converting dopamine, or converting L-dopa, into things you don't really want it to be. You just want it to become dopamine, nothing else. Right? So you stop COMT because it's converting all your L-dopa into something other than what you actually want it to be. Dopamine availability increases with amantadine. That's the other guy here. Right? You're going to let the dopamine sit here so that there's more activity. And then dopamine agonists, which act like dopamine, are your last medication that we just looked at. Right? You also have MAO-B inhibitors, selegiline and rasagiline, which also are mainly important simply for stopping conversion of dopamine into shit you don't want. You just want everything to stay dopamine. That's it. Right? Now, there's a big problem, a huge problem with using all of these medications, because look at this graph that UWorld Step 1 had to kind of help teach how levodopa and carbidopa therapeutically kind of stop working over time, right? So, right, let me see, what is it? Okay, so this is called LID, right, levodopa-induced dyskinesia. What is illustrated on the graph is that over time, the amount of levodopa you're producing is decreasing. So it takes higher dosages of levodopa to get up to functional levels, such as out of the purple zone. The purple zone is off. This is the off state. So you don't want to be in the purple zone, but then if you go too high, you hit the yellow zone, which is the dyskinesia area. So you want to be in the blue area. Now, levodopa administration, the first time you give it, is always going to be in the blue area. So the first time you take levodopa, an early treatment is very easy. You're going to be in the blue area. There's not much pink or yellow area. But as time continues, you start seeing this diphasic dyskinesias, these moments of dyskinesia that come and go. Then you're back in the nice blue area. Then boom, you go up to here again, right? Peak dose dyskinesias. So you see dyskinesia again. You lower the dose a little bit. Eventually, what starts happening is, if you don't actually change the dose, which is what you're seeing in this graph, you're seeing they didn't change the dose. That's why the sine wave that we're seeing here is staying the way it is. Right? It's going as high as it always was, and it's coming back down to where it was. Eventually, the response to levodopa shortens over time, right? And it gets really bad to a point where levodopa is no longer helping. Because if you take levodopa, you end up getting dyskinesia. Another thing to keep in mind is what happens in this question. 70-year-old man comes to a physician with muscle rigidity that impairs his daily activities. So it's rigidity, which means you don't have dopamine, which means you must have Parkinson, right? He was diagnosed with Parkinson 5 years ago and takes levodopa carbidopa. His initial response to medication allowed him to continue all of his usual activities because it was nice and easy in the blue area. Recently, the patient has been experiencing episodes of sudden, restricted mobility lasting several hours. That's your dyskinesia. And sometimes he freezes altogether. These episodes alternate with symptom-free periods in which he is mobile and feels well. Hence the pendulum type of movement this is having. During discussion of this patient's fluctuating mobility, what should the physician emphasize? This is very much like an ethical type of question, conversation-based question. You should emphasize that drug response is unpredictable. Right? And then this image was again given right there for a response window. Patients have good mobility during the on period, which is when you're in the blue area, and increased rigidity during the off periods. This is the on-off phenomena. As treatment continues, the therapeutic window for levodopa becomes smaller. That's a key thing to keep in mind. The on-off phenomenon, the The fact that this is only going to get worse the longer you keep taking levodopa. Right, so they talk about it in the book too, the on-off phenomenon. All right. Now that being said, that's generally all you need to know for the medications you'd be taking, right? So anticholinergics, dopamine agonists, increase dopamine availability, prevent dopamine breakdown, right? So Sertraline, tocopherol. So now let's go back and look at all the practice questions we have down here. Okay, so first question, 74-year-old man. So 74 is a pretty big age, so whatever this guy has, he might have had it for a long time. 74-year-old man is brought to the office by his wife due to change in behavior. Over the last year, he has had difficulty recognizing his grandkids and has gotten lost in his local grocery store more than once. This is really starting to look like Alzheimer's so far. He enjoys playing Sudoku in the Sunday newspaper, but has had increasing difficulty completing the puzzles. He has also been increasingly distractible during conversation and says that he sometimes sees animals in the house despite the couple not owning any. So those are some visual hallucinations, which is not an Alzheimer's thing. So right away we're done with picking Alzheimer's as an answer choice. But he does have visual hallucinations, so you gotta keep that in mind. Right, so we'll say sees animals, right? We'll just highlight that. Yeah, sees animals, and then the changing behavior, no, not so much. Difficulty recognizing, right, which is memory loss. So going on, he has not seen a doctor in more than 20 years and takes no medications. His wife says that he started slowing down and talking about stiffness and a tremor about 4 years ago. So stiffness and a tremor comes back to thinking of Parkinson's, which was before he experienced any behavioral symptoms. They never sought medical care because they assumed it was just part of getting older. Exam shows intact cranial nerves as well as a pinprick and light touch sensations. So the tracts are working pretty well. There is rigidity in the bilateral upper and lower extremities that is worse on the left. Tremor is present in both hands at rest and is worse in the left hand. Movement and speech are slowed. Gait is unsteady and marked by a shortened stride. What is the most likely diagnosis? So now, they had multiple answer choices, but most people picked the correct one, which is Parkinson's disease dementia. Right? This patient has Parkinson's disease. That's all this patient has. The seeing the animal thing was probably the only little far-fetched bit of a thing that they threw in there. But you do get hallucinations in Parkinson's disease. We saw that. Right? They said what did they? I don't know if they said it here. Let me see back in step 1. Parkinson's disease. No, they didn't really mention it at all. You also get hallucinations here as well, but again, they're not really mentioning it. Because hallucinations in general, are a concept of just your brain not being where it used to be, And of course, anytime you have too much dopamine, that is going to cause hallucinations. There isn't, a very specific symptomatic breakdown of all the things that can occur, because things can occur that occur in other places. In fact, it was because of the hallucinations that 35% of people chose dementia with Lewy bodies, where with Lewy bodies you get hallucinations, right? But this wasn't Lewy body dementia, because Lewy body dementia would only have Lewy body dementia and nothing else, right? We saw the dementia thing as well. If we come down a little bit here, Lewy body dementia has visual hallucinations and dementia with fluctuating cognition, but they don't really have, full-blown Parkinson type symptoms. They would have some Parkinsonism, but the bigger deal here would be the visual hallucination aspect, right? And it's called Lewy body dementia only if the cognitive and motor symptoms occur in the same 1 year time span. Right? This was a critical little thing that we just recently talked about, I think in the step 1 room. But now that we're here, we look at it in the CK class as well. We talked about it in CK as well when we looked at Lewy body dementia earlier. Right? So the things have to occur in the same year. Both the cognitive and the motor symptoms have to occur in the same year for you to call it Lewy body dementia. So that was already wrong as choices because things didn't occur in the same year. And then if it's occurring over more than 1 year, then it's dementia secondary to Parkinson's disease, which is our question. And you see how dementia secondary to Parkinson's disease would have visual hallucinations. And this is happening right here. It's all part of the same thing. So again, I don't think the book has a good way of breaking it down and teaching it. It's kind of messy the way they have it organized there. But that's the point. So this difference between Parkinson's disease dementia or Lewy body dementia really came from whether or not everything occurred in the same 1 year. But it didn't. Right? He had tremors that started 4 years ago, and he's only recently starting to see visual hallucinations. So that's Parkinson's disease dementia. His more than 4-year history of asymmetric rigidity, resting tremor, and bradykinesia is consistent with undiagnosed Parkinson's disease. About 1/3 of patients with Parkinson's disease get Parkinson's disease dementia. Although signs and symptoms are similar to those of Lewy body dementia, by definition, Parkinson's disease dementia is diagnosed when the Parkinsonism predates cognitive impairment by more than 1 year. They didn't occur in the same year. This pattern is clearly evident in this patient, where his Parkinson's stuff occurred long time ago, right, more than 4 years ago, and it's just now they started seeing his little visual hallucinations. Right? So key typical thing there. They go on to say PDD, Parkinson's disease dementia, typically presents with executive and visual spatial dysfunction, getting lost in familiar locations with only mild memory impairment at first. Although visual hallucinations, delusions, and sleep disorders may occur in Parkinson's disease without dementia, these symptoms occur at higher rates in Parkinson's disease dementia. Right? So again, all of those things delusions, hallucinations can occur in Parkinson's disease. It's not something that we talk about that much, but you should keep in mind that all of those are also things that can occur in Parkinson's disease. It is not impossible for someone with Parkinson's disease to have hallucinations. It can happen. The cognitive impairment of PDD may be treated symptomatically with cholinesterase inhibitors. Psychotic symptoms may be treated with a dose reduction of anti-Parkinsonian agents or low-potency antipsychotics like pimavanserin or quetiapine. I've never seen pimavanserin as an S choice, but this was actually a question that put that in the explanation. Very weird. I've never even heard of that. Quetiapine I've seen as S choices over and over. And again, dementia with Lewy bodies, everything would occur in the same year. That's it. Right, so that was the only way to differentiate between those two answer choices, which are both respectable answer choices. So it's nice that people didn't really pick anything stupid, right? Here, 29-year-old man comes to the emergency department with progressive bilateral lower extremity weakness. He has no history of trauma or back pain. He had trigeminal neuralgia 3 months ago and a self-limited upper respiratory illness 2 weeks ago. Temperature, blood pressure, and pulse are all good. So the only really concerning thing we've seen so far is upper respiratory illness 2 weeks ago, which on step always leads to something really bad. Physical exam shows increased resistance to passive flexion and extension of the lower limbs. Deep-tendon reflexes are 3+, and plantar reflexes are upgoing bilaterally. So he has a positive upper motor neuron injury sign. So upper motor neuron injury out of nowhere after upper respiratory illness is something that should ring a bell for stuff. Other than that, we don't really see anything else that's chronic about him. They go on to say that there is decreased vibratory and positional sense in his left upper extremity, but no other sensory loss. So losing vibratory and position sense would be a dorsal column thing. A lumbar puncture is performed. What is the most likely to be found on CSF analysis of this patient? And there were two answer choices that dominated. Oligoclonal bands, 40% of people chose it, right, which should be for multiple sclerosis. And then albuminocytologic dissociation, which is more of a Guillain-Barré thing. So when I said that the upper respiratory illness leading to a upper motor neuron sign should ring a bell for something, that would be the Guillain-Barré syndrome, which would have albuminocytologic dissociation. However, Guillain-Barré doesn't really cause only this. You would also have the ascending paralysis, which we don't see in him. We don't see any ascending paralysis in this person. Right? There's physical exams showing resistance to passive flexion and extension, but that's not paralysis. That's not an ascending paralysis. His neurologic deficit is disseminated in space and time. with the trigeminal neuralgia he had 3 months ago, and the spastic lower limb paralysis and left upper limb sensory loss right now, which are all over the place, indicate a diagnosis of MS. When the diagnosis is suspected, but the clinical exam or MRI is not classic, lumbar puncture should be performed for CSF analysis, so it's not the first thing you order. Such analysis shows oligoclonal bands in nearly 90% of patients, which is pretty much diagnostic of MS. In MS, the opening pressure and CSF appearance are typically normal. CSF analysis usually shows a normal cell count with T lymphocyte predominance. There is usually a normal total protein concentration, but immunoglobulin are high relative to other proteins. Right? So albuminocytologic dissociation, that was the other answer choice. Elevated CSF protein with a normal cell count, that's the dissociation you're looking for, is characteristic of Guillain-Barré syndrome, which would have rapidly progressive ascending paralysis preceded by infection, which he had 2 weeks ago. Associated symptoms include reduced and absent reflexes. He has 3+ absent reflexes, not reduced. Right? He has some flexing that's occurring that isn't stopping. So definitely not Guillain-Barré. Next question. This one really caught a lot of people off guard. Very interesting question. 36-year-old woman is evaluated in the clinic due to left-hand clumsiness. She works as an office secretary and has been having difficulty typing. 6 months ago, she had an episode of vertigo. So let's pick that now. So she's got left-hand clumsiness. She's got difficulty typing, right? And then she had vertigo. Difficulty walking that improved after several weeks. She also has history of bipolar disorder and takes valproate. Okay. Oh, my kitty's arrived. Bipolar disorder, valproate. On physical exam, she is asked to close her eyes and stretch out her arms with the palms facing up, like this. Right? So almost like begging for something. So close your eyes and stretch out your arms with your palms facing up. Right? Several seconds later, her left arm involuntarily drifts downward and the palm turns toward the floor, so you can see what's happening. This is happening in her naturally in a couple seconds of time. What do you want? Hi. So this symptom that she's having is called the pronator drift, and it's actually giving away what's wrong with her. So they go on to after that physical exam. Basically, they're just asking what best explains the findings observed in her. Now you can see everyone basically messed up. Only 20% of people picked the correct answer, which is that this was a pyramidal tract lesion in her. But who's to say if they were even confident in what they picked, right? They might have just been guessing. 40% of people, the largest group of people, actually just picked cerebellar dysfunction. But keep in mind that this was an easy answer choice to knock out simply by understanding that if you make a person stand up with their eyes closed and their cerebellum doesn't work, they would fall, right? They would fall. Usually with cerebellar dysfunction, we saw that you fall onto the same side as where your lesion is. So if you have left cerebellum dysfunction, you start falling towards the left side. That's not happening here. She's not falling. Nor does she complain at all about ataxia, which is one of the major symptoms of cerebellar dysfunction. So cerebellar dysfunction made no sense as an answer choice. Just didn't make any sense. After that, 25% of people chose that, what best explains findings observed in her? Impaired proprioception. No, so proprioception means that if you close your eyes and, let's say I move your hand to a certain direction and you're maybe holding your hand like pointing towards the far out leftwards, laterally, and you close your eyes and then I ask you where is your hand, you wouldn't know that it's pointing there. Because I moved it there while your eyes were closed, you didn't see me moving your hand in that direction, so you just wouldn't know that it's there. Proprioception is a knowledge thing. It's whether or not you know where your limbs are without looking at them. We talked about this in terms of walking. When we walk, we don't look at our legs. Oftentimes nowadays we're walking looking at our phone, looking at something in far distance. Most times when we're just walking looking forward, we can't even actually see our legs. But thanks to proprioception, you always know where your legs are so you can continue maintaining the correct motion of walking. This pronator drift that occurred is not because of proprioception. So it was just a pyramidal tract lesion. Lala, come over here. So they tell you here in the picture, pronation more than supination, right? Your supination is like asking for soup, so that's why your hand is pointing upward. You can put a bowl of soup over here. Just remember it like that. And pronation is to move it down like this. So this activity of what she's doing is pronation, right? And pronator teres is the muscle that allows you to do it. So you learn that when you're in musculoskeletal anatomy. So this young woman with neurologic deficits disseminated once again in time and space most likely has I wrote that twice. Most likely has MS. Pronator drift is a physical exam finding that is relatively sensitive and specific for upper motor neuron or pyramidal corticospinal tract disease. Most people, when I talk to them about pronator drift, most students, when I talk to them about it, have no idea that it's related to multiple sclerosis. It's not really mentioned. It's not mentioned in the Step 1 book at all. I'm not sure if they mentioned it in First Aid 2021, but up to First Aid 2020, it wasn't mentioned in multiple sclerosis at all. Also understand that the things that are happening to her, you always want to see, right? Most people, when you look at the brain, most people would have injury or some kind of issue in one part of the brain, right, which is going to cause symptoms in whatever that part is supposed to go to, right? Maybe it just goes to this part of the hand, or maybe it only goes to some part of your left leg or something, right leg, and that's it. And all your symptoms are going to be in that one area because your injury is in one area. But this patient has symptoms all over the place, which means that she has injuries disseminated in time and space. The time aspect being obvious from the fact that she's had different things occurring over the last year, right? So that's kind of how you figure that part out. Upper motor neuron lesions cause more weakness in the supinator muscles compared to the pronator muscles of the upper limb. As a result, the affected arm drifts down and the palm pronates because the supinator isn't working, right? So the pronator is just overcoming the power, right? Romberg sign would be the thing you would look for with proprioception, right? Proprioception is evaluated by passively moving the distal phalange of a digit up and down and having patients identify of movements with their eyes closed. See, you're moving something in the patient and you're asking them, where is it? And they'll have to tell you, are you pointing up or are you pointing down? And they can't look at their finger. So then they can't tell you if they're pointing up or pointing down. It is also assessed with the Romberg test, in which patients are observed for unsteadiness as they stand with their feet together, arms to the sides, and eyes closed, standing like this. They can't do it. You end up making their heels touch, and when their heels are touching, everything is pivoting at that one point. And because everything is pivoting at that one point, they lose their balance without their dorsal column. They can't sense where everything is. They can't figure it out anymore. And you see exactly what you see in this picture. This kind of loss of posture. So really good multiple sclerosis questions, especially because we recently just talked about that, right? We just did where was it? Couple pages, couple areas up actually, the demyelinating lesions, right? So these are your multiple sclerosis questions from back of those topics. I think that was like 2 videos ago. Next one here, demyelination of neuroaxon. Another way you're getting tested on multiple sclerosis. See, these questions are looking very different from the multiple sclerosis questions we talked about when we were in Step 1. When we were in the Step 1 book, we looked at all these multiple sclerosis questions from there, and they were all just about the same kind of thing. Oligodendrocytes, demyelination, or talking about the decreasing in length, right, or decreasing in distance and stuff like that. Very silly questions, Step 1. But here they're becoming a little more complex about it, right? The presentation isn't exactly super obvious, and they're talking about things that aren't super high yield, super common. No one has really heard of pronator drift until you've done this question. So here you have a 33-year-old young woman, right, comes to the office with severe bilateral facial pain for the past several days. So that sounds like trigeminal neuralgia. She reports sharp shooting pain that is confined to her cheeks and jaws. That's definitely trigeminal neuralgia. Lasts several seconds and occurs 10 to 20 times a day. The pain is sometimes triggered by a cold breeze, brushing her teeth, or chewing. She has been taking ibuprofen for the pain without much relief because it's not a real pain, it's a nerve pain. She has never experienced this condition before, but 6 months ago, so now immediately, this should ring a bell for dissemination in time, because this is a young woman with neurologic things, right? Neurologic things. So 6 months ago, she had numbness of her right hand that lasted about 2 weeks ago. So we just went from something happening on the face to now something happening in the right hand. That's dissemination in space. And this thing that had occurred 6 months ago, that's dissemination in time, right? 4 weeks ago, another thing, she was treated for acute sinusitis. She is a primary school teacher and doesn't use tobacco or drugs. Vitals are fine. Physical exam, a similar pain is elicited by lightly touching her cheeks. So she still has the same facial trigeminal neuralgia issue. Otherwise, neurologic exam demonstrates no focal deficits. What is the most likely cause of her symptoms? Demyelination of the nerve axon. 50% of people picked it. But a grand, practically other half of people picked nerve inflammation from viral reactivation, which would basically be your herpes zoster, right? But herpes zoster doesn't just cause nerve inflammation. You would have nerve inflammation of the face, but you would also have vesicular lesions on the same half of the face. She doesn't have any rash whatsoever. You can't get shingles without a rash. Shingles comes with a very vesicular rash, as well as nerve pain, very, very painful nerve pain, often going from V1, so it starts in the eye, right? The ophthalmic version of trigeminal nerve. But she just has trigeminal neuralgia, not herpes zoster. So she has trigeminal neuralgia, a disorder characterized by recurrent and sudden onset severe stabbing pain along V2 and V3, right? Hence why it's occurring with her cheeks and jaws and is worsened with brushing her teeth. Herpes zoster stuff is V1, starts in the eye. It's also called herpes ophthalmicus, as they wrote over here. A disorder characterized by recurrent V2, V3 inflammation, usually unilaterally. The episodes last for a few seconds to minutes and can be triggered by all kinds of stimuli. Demyelination of trigeminal nerve axon at the nerve root leads to the nerve root leads to improper signaling of the nerve and paroxysms of severe pain. Her episode of right hand numbness that lasted 2 weeks and spontaneously improved was likely her first symptom of MS. Right? That's where it started. So dissemination in time and space is what we're really trying to get really professional at catching in all these questions, which are not super obvious. But one thing is definitely obvious in all of them. They're young patients. Right? They're not 50 and above. They're young patients, mostly going to be female, and all of them are going to have symptoms that are all over the place. And the question will always mention something stupid that's there to kind of throw you off, right? This first question mentioned having an upper respiratory infection 2 weeks ago, which threw a lot of people off into thinking Guillain-Barré. And this one was only it threw people off because of pronator drift. This one here, they mentioned that she has sinusitis to really make you think, oh, this must be some kind of infection-related stuff, but it wasn't. It definitely wasn't. Right? She just has sinusitis. It can happen to anyone, so that's different. Last question on this page, 56-year-old man. So now it's someone over 50, so this is going to be a little different. Probably not multiple sclerosis, which tends to present earlier, right? So 56-year-old man comes to the office due to burning pain in his feet. So this could be diabetic neuropathy, burning pain in his feet. Immediately you should start thinking of treatment as well. You would just give the guy gabapentin. He initially began experiencing pins and needles in his toes several months ago, which gradually worsened to involve the entire foot. Lately, he has had burning and cramping pain daily in both feet, which is more pronounced at night. He has had occasional back pain but has no chronic medical conditions and takes no medications. He is a construction worker and is frequently exposed to vibrating machinery. He does not smoke but drinks 4 to 6 beers daily and more on the weekends. Vital signs are within normal limits. Physical exam shows loss of bilateral ankle reflex and impaired light touch and vibration sense in both feet. The remainder of the exam reveals no abnormalities. Hemoglobin A1C and methylmalonate levels are within normal levels. So hemoglobin A1C being normal means this is not diabetic neuropathy, and methylmalonic acid being normal means this isn't due to folate or any of that stuff deficiency. So what's the most likely cause? Well, it was again with people split up, right? Half the people chose toxic neuropathy, and half the people chose compressive neuropathy. So, how do you break this down? Well, he has symmetric distal polyneuropathy. Peripheral neuropathy is often idiopathic but can be caused by a wide variety of toxic and metabolic disorders that impair axonal function. Common causes include diabetes, hypothyroidism, vitamin B12 deficiency, and medications like cisplatin. However, his heavy alcohol use, right, and that's the thing that you need to focus on. He drinks 4 to 6 beers daily and more on the weekends. Right? So having 4 to 6, so imagine just 6. If you have 6 cans of beer every day, that's alcoholism, right? Having 1 to 2 cans of beer every day is normal. And there's a lot of people that do that, having 1 to 2 cans of beer every day. But not 4 to 6. And then you don't amplify that with having more on the weekend. His heavy alcohol use makes alcoholic neuropathy likely. Chronic excessive alcohol ingestion is neurotoxic and results in an axonal neuropathy characterized by a reduction in the number of small, myelinated and unmyelinated fibers. It may also occur alone or in association with thiamine deficiency, which is one of the key deficiencies in alcoholics. Alcoholic neuropathy typically results in symmetric distal polyneuropathy. Symptoms include paresthesia, burning pain, and numbness. Loss of detent reflexes is common and almost invariably begins with loss of the ankle reflex. So the loss of the ankle reflex could be a compression of one of your the plexuses of the, what was that plexus called? Let me find it again. This one, lumbosacral, right? So lumbosacral plexus being compressed, which of course then, this one here would be the one where you would lose your ankle reflex, right? Which would be the Achilles reflex. Right? All of them have different reflexes you lose, but this one with the Achilles stuff, if the correct answer was compressive problem, then the compressive problem at S1 would present with sciatica. And this guy is not presenting with sciatica. He doesn't have a shooting pain down the back of his leg. Right? He just has back pain, occasional back pain, which is normal in many people. And then mostly just neuropathic stuff in his legs. Physical exam reveals loss of light touch, vibratory sense. Gait ataxia is also common, right? In alcoholics, they have ataxia. Cessation of alcohol is associated with improvement in symptoms, and thiamine supplementation is recommended to prevent secondary neuropathies. Gabapentin and tricyclic antidepressants are often used to treat refractory pain. Compressive neuropathies can affect a nerve root or a solitary nerve, but it typically results in back pain with weakness of the innervated muscles and radicular paresthesia. Common peroneal nerve compression results in foot drop and dorsal foot paresthesia. His stocking-like distribution does not follow a single nerve pattern. Right? So that's peripheral neuropathy due to toxic shit. Last thing they talk about here is restless leg syndrome, which is the urge to move legs, more prominent at night and associated with dysesthesias that are relieved with movement. Associated with neuropathy, iron deficiency anemia, treat with dopamine agonists and or gabapentin, and they should get better. It's a very straightforward thing. You won't see any other weird symptoms. It should mainly just be focused on the leg movement thing, maybe some anxiety or something also, but just leg movement. No hallucinations, dementia, movement disorder, nothing else like that. Just the only movement disorder they have is this. They can't stop moving their legs. They like moving their legs. So they'll ask you, what should you give the patient? Give them ropinirole. Give them a dopamine agonist and things will be okay. That's it. Alright, so that's it for now. In the next video, we'll move on to our neoplasms in neurology.